Assalamu alaikum. The injury of the external branch of the superior laryngeal nerve in thyroid surgery often go unnoticed. The symptoms are subtle, the laryngeal features are variable, and the diagnosis may be challenging. In this presentation, we shall go through the steps that should be taken after thyroid surgery to diagnose a possible injury to the external branch of the superior laryngeal nerve. We shall go through what would be expected after the injury of the nerve in terms of voice changes and laryngeal features. We'll discuss the most common vocal symptoms after injury, the laryngeal features more specific to the injury of the external branch of the superior laryngeal nerve, and the special features that should be elicited during laryngeal stroboscopy, the analysis of a voice signal, and the gold standard, the electromyography of the cricothyroid muscle. The true prevalence of injuries to the superior laryngeal nerve, or more specifically the external branch of the superior laryngeal nerve, is unknown. The reported prevalence varies a lot, between 3% and up to 58% in one series. Many cases would go undiagnosed. It's difficult to detect the injury and its sequelae because of the subtle symptoms and the wide variability in the clinical signs and laryngoscopic features. It may be particularly noticed by patients who are professional voice users, where subtle changes can have a more noticeable effect on their voice and lifestyle. Voice changes after thyroid surgery are multifactorial. There may be around a dozen of different reasons for these voice changes, including the much feared recurrent laryngeal nerve dysfunction. Other causes include endotracheal intubation that may cause mucosal edema or lacerations or arytenoid dislocation, variability in the cricothyroid joint tolerance for sliding movements, surgical scarring that may and perhaps transaction of the strap muscles, mucosal disease of the vocal folds including dryness or edema, direct surgical injury to the cricothyroid muscle itself during thyroid dissection, the compensatory action of other intrinsic laryngeal muscles, laryngeal fixation following scarring and fibrosis, pre-existing conditions of the thyroid like hypothyroidism or systemic factors like aging, the interconnection between laryngeal nerves, the superior laryngeal nerve may interconnect with the recurrent laryngeal nerve, the so-called the human communicating nerve, and finally the variable patterns of denervation, because denervation is not an all or none phenomena. There is partial with different degrees denervation and also partial with different degrees of reinnervation. What would be expected if the cricothyroidus muscle is paralyzed? The cricothyroidus muscle is formed mainly of two bundles, the parus recta and the parus oblique, perhaps also with a contribution of a third bundle from the inner perichondrium of the thyroid cartilage. Activation of these muscle bundles with the excitation of the external branch of the superior laryngeal nerve would cause movement of the cricoid cartilage relative to the relatively more fixed thyroid cartilage. The cricoid would be displaced mainly posteriorly and also slightly higher position, and the arytenoid cartilage on top of the cricoid would be also displaced more posteriorly and slightly higher position. This would cause stretching of the vocal folds along its anteroposterior direction, but perhaps more importantly would cause a stiffening increases in the stiffness of the vocal fold and also its tension in both the core layer and the cover layer of the vocal folds. This would be translated into changes in the fundamental frequency of the vocal fold vibration, because the changes in vocal fold stiffness is the prime adjusting factor for fundamental frequency of vocal fold vibrations. It is the cricothyroid muscle that causes most of the changes in the stiffness and the length of the vocal folds, with some contribution from the thyroarytenoides muscle. And changes in the vocal fold stiffness, the limitation of the stiffness and the tension in the paralyzed muscle would cause the vocal fold vibration problems and consequently the changes in the vocal signal. The external branch of the superior laryngeal nerve does not only activate the cricothyroid muscle. There is now good evidence that the external branch of the superior laryngeal nerve can also contribute in the activation of the vocalis muscle, the thyroarytenoid muscle, through either direct innervation of the anterior fibers of the muscle or indirectly by communicating branch with the recurrent laryngeal nerve. This communicating branch is called human communicating nerve, which is found in just less than half of the cases. This has obvious clinical implications. It was known for a while that activation of the cricothyroid muscle through activation of the external branch of the superior laryngeal nerve can also activate the thyroarytenoid muscle, and this was registered by nerve monitoring intraoperatively by electrodes placed around the endotracheal tubes. Just a routine and a quick laryngeal examination for patients who have thyroid surgery to assess whether the superior laryngeal nerve was injured or not may not be enough, because there will be wide variations in the laryngeal features for superior laryngeal nerve palsy. Such a wide variation is the cause for this. There is no general consensus about which features are diagnostic for the paralysis. The causes are multiple. Number one is the variability in the movement around the cricothyroid joint. There are two types of movement, posterior and oblique and superior displacement of the cricoid with the arytenoids on top. It is the horizontal displacement that really causes the stretching of the vocal fold along its anteroposterior direction and increases the fundamental frequency. If most of the horizontal displacement is preserved, then there will be no much features of palsy detected. The other is, when is this examination done? If it is done quite a few weeks or few days after the injury, there may be some attempts at compensation by the other intrinsic laryngeal muscles, including the thyroarytenoides and the lateral cricoarytenoid muscle. Both muscles can redistribute the tension along the vocal folds and also affect its length, and this would cause more variability in the laryngeal features. The third, which is perhaps more important, is which phonatory tasks are the patients asked to do during the examination. If it is just the routine examination with adduction and abduction, no specific features can be elicited. Some specific maneuvers would be required by the patient to do, including repetitive maneuvers in order to fatigue the paralyzed muscle before the diagnosis can be established. What are these features of superior laryngeal nerve palsy? This has been the subject of much debate over the last 100 years or so, as Mygent has described some of these features in 1906. He noted that in the case of paralysis, the gross abduction and adduction of the vocal folds will still be intact, but the glottic chink would run obliquely and the posterior commissure would rotate towards the paralyzed side. This may be due to the asymmetry in the vocal folds length and tension due to paralysis of one cricothyroid muscle. He had also noted that the paralyzed side, the vocal fold will appear a little bit bowed and a little bit shortened. It was also noted that due to this rotation of the posterior commissure towards the paralyzed side, that the ipsilateral epiglottic fold will appear shorter than the contralateral fold, and that the piriform sinus on the contralateral side would appear more open due to this rotation of the posterior commissure. Would possibly explain the dynamic rotation of the posterior commissure during phonation in the cases of superior laryngeal nerve palsy. Say it is the right side that is paralyzed, there will be only one active cricothyroid muscle on the left side. During normal phonation with habitual fundamental frequency, there will be no much activation of the cricothyroid muscle. The glottic configuration would almost be normal with normal abduction and adduction and normal position of the glottic chink. However, when there is a need to raise up the fundamental frequency, the speech fundamental frequency, there would be activation of the unopposed left cricothyroid muscle. This is going to cause the rotation of the cricoid cartilage relative to the relatively more fixed thyroid cartilage. This anti-clockwise rotation of the cricoid would cause displacement of the posterior commissure towards the paralyzed side. The reverse would happen if the relatively more fixed thyroid cartilage would rotate in relation to the cricoid cartilage. Such a rotation, the clockwise rotation in this example, would cause the posterior commissure to rotate towards the contralateral side rather than the paralyzed side. Roy et al. Had experimentally induced temporary paralysis of the external branch of the superior laryngeal nerve by injecting a local anesthetic in some volunteers over the site of the nerve. And then he asked the patient to do some special phonatory tasks. When the patients are asked to do the glissando up maneuver, raising up their fundamental frequency, he had noticed that the posterior commissure would be rotated towards the paralyzed side, the anterior commissure would be rotating towards the contralateral side, and that the petiole of the epiglottis relative to the anterior commissure would be displaced towards the paralyzed side. Also, in raising up the fundamental frequency, he noted better adduction of the vocal folds. But more interestingly, when the patients were asked to do another phonatory task, alternating rapidly between maximum vocal fold abduction, like for example during sniffing, and high-pitched phonation, saying E with a very high pitch, then he noticed that such a rotation is actually reversed, and in 50% of his subjects, the posterior commissure rotated towards the contralateral side and the anterior commissure rotated towards the ipsilateral side. Later, the same team confirmed the experimental findings in a report on patients' clinical cases who had partial or complete denervation of the cricothyroid muscle and showed that the results are also validated in real-life situation. And these findings were confirmed by several other authors. In the case of external superior laryngeal nerve palsy, there will be almost normal abduction and adduction of the vocal folds, and during normal phonation with habitual fundamental frequency, there may be no much alteration in the position of the glottic chink in relative to the posterior commissure and the epiglottis petiole. But during special phonatory maneuvers like a glissando up maneuver, a posterior commissure would rotate towards the paralyzed side and the petiole of the epiglottis would rotate towards the paralyzed side in relation to the anterior commissure. Findings were reported by Edelson and Tucker, who had also described the rotation of the posterior commissure towards the paralyzed side. In addition, there will be a little bowing of the vocal folds on the paralyzed side with some hypomobility of the vocal fold on the paralyzed side and minimal mucosal asymmetry between the waveforms of the two sides. Robin et al. Had confirmed that by repeating certain phonatory tasks rapidly and for a certain amount of time, this would cause the very minimal or subtle changes in the laryngoscopic features to become more obvious and would help in the diagnosis of the external branch of the superior laryngeal nerve palsy. So patients are asked to repeat certain phonatory tasks rapidly, like saying E and he and alternating that with sniffing several times rapidly, and this would show more clearly the vocal fold lag, the sluggishness in the movement of the vocal fold and the paralyzed side. This would become only obvious after doing these repetitive phonatory tasks. This observation of sluggishness of the vocal fold on the paralyzed side in relation to the vocal fold on the normal side would become more evident after repeated phonatory tasks like the one described by Robin. The vocal fold on the normal side would be quicker to close up the glottis during adduction. There will be a relative lag, vocal fold lag on the paralyzed side due to the external branch of the superior laryngeal nerve palsy. Robin proposed that the vocal fold hypomobility during fatiguing after these repetitive phonatory tasks could be diagnostic of the external branch palsy. Video stroboscopy will be required to report and register these very subtle changes. A video stroboscopy would show the phase difference between the two sides, with the paralyzed side being a little bit more sluggish in relation to the normal side. The normal side would lead the abduction and adduction of the glottal cycle, and the mucosal wave would appear earlier on the normal side than it is on the paralyzed side. This vibratory phase asymmetry with the vocal fold on the paralyzed side by the external branch of the superior laryngeal nerve being slower than the normal side is quite common, but it's not specific to external branch of the superior laryngeal nerve palsy, because it can be seen in some normal individuals and can also be noted in cases of recurrent laryngeal nerve palsy. The increase in the asymmetry between the paralyzed side and the normal side would lead to increase in the aperiodicity of the voice signal and chaotic vibration as well. Are the commonest voice symptoms for these patients? The commonest symptom will be voice fatigue, described by just less than 3/4 of the patient after a month of the thyroid surgery, followed by difficulty with the singing voice and difficulty with high pitch in about 2/3 of the patient, followed by difficulty with loud voice in just less than half of the patients, and very rarely these patients would describe hoarseness of voice. Notice that with time all these symptoms would tend to be controlled with the compensation by the other internal laryngeal muscles. On voice analysis, it would appear that the speech fundamental frequency would drop significantly in the patient who had paralysis of the external branch. There would be partial recovery after 6 months, but it's not going to return back to their preoperative levels. The other factor would be the range of the speech fundamental frequency between the minimum and the maximum possible speech fundamental frequency. Again, there would be a significant drop after the surgery, but it's going to recover gradually, but it may take as long as 6 months to come back to the preoperative levels. The most consistent effect on the voice in patients who had either external branch paralysis or external branch block experimentally would be this reduction in the range between the highest and the lowest obtainable frequency, and it would be consistent across the board while producing normal phonation with normal loudness. There would be a significant drop in the range, same while producing a soft voice and same while producing a loud voice, and also while trying the glissando up maneuver. But the gold standard for establishing a diagnosis of external branch of superior laryngeal nerve paralysis remains the laryngeal electromyography. This is the most useful and precise method of establishing a diagnosis by detecting signs of denervation. It should be carried out in all medico-legal cases and should be considered before any attempts at restorative surgery for improving voice be considered. The applicability is, however, limited in the routine ENT practice because it's invasive and because it is technically difficult. It's also limited because the interpretation of the laryngeal electromyography traces are very much operator dependent. By this, we come to the end on this presentation on how to diagnose the paralysis of the external branch of the superior laryngeal nerve after thyroid surgery. Assalamu alaikum.